So good afternoon to all, and you are welcome again in our continuous educational ABC courses. And on behalf of CRG, Professor Fadi Farahat, and myself as representative of AMAC, we are welcoming you today at the ABC Oncology educational course on prostate cancer. The activity, as you all know, it's endorsed by ASCO, UICC, and EMAC, and awarded by 2 CMEs. Our panelists for our first part or first session, they will present our speakers. So I will present them. Dr. Muna Ayadi, Associate Professor of Medical Oncology and Consultant Oncologist at Salah Zayed Institute in Tunisia, and Dr. Hassan Al-Hassan, Consultant of Medical Oncology in Syria, and Dr. Amal Nassar, Hematologist Oncologist at Al-Zahra Hospital, UMC in Lebanon. So you are welcome, and I think one of you as a panelist will present Dr. Fadi Farahat, and then Dr. who is going to present cases and will discuss it, and then Dr. Sameh Hashim. Please, the floor is yours, panelists. Anyone wants to present our first speaker, Dr. Fadi Farahat? Dr. Bassem?
Dr. Bassem is not panelist, so I can start by presenting myself.
Okay.
Amal, go ahead.
يعني ما في أشهر من أن يعرف دكتور فادي. He is a professor of hematology oncology in Hamoud Hospital, and he has also his private clinic and in multiple hospitals. The floor is yours, Dr. Fadi.
Thank you very much. First of all, I would like to thank Dr. Sami Khatib. I would like to thank our panelists and speakers for accepting to join us in the ABC activity. And I would like to thank Science Pro for their support. What I will try to do is to present some of our cases in order to go through the presentations later on. So the first case, Vanessa, you have to change this photo. I am older than that. هذه الصورة بعدها قديمة لازم نغيرها. So the first case, it's an 89-year-old patient, 7 years after his radical prostatectomy with initially Gleason 7, 3+4. He had perineural invasion initially. Perineural invasion was positive and margins negative, non-metastatic with the PSA initially at 5.2 nanogram per milliliter. For sure, after surgery, PSA was undetectable and started to rise 2 years after surgery. Definitive radiotherapy to prostate bed was done. 2 years after irradiation, which makes it 4 years after the prostatectomy, PSA again began to rise, and the staging, the workup showed no metastasis. The patient started agonist LHRH plus anti-androgen, and PSA dropped. After 8 months of the combo therapy, the PSA started to rise slowly, 0.9, 1.3, and 12 months. And next 12 months, PSA increased to 2.1. So it's a case with non-aggressive disease. Again, the workup showed no metastasis, and testosterone level was 3 nanogram per deciliter, which is really good since it's less than 25, and there was no urinary symptoms. So here I think you skipped something. The PSA was increasing, and the patient has a rise in PSA. Okay, what should we do in this case? So the question is, should we discontinue hormonotherapy and start docetaxel, or give discontinue therapy, give sipuleucel, or hormone therapy and give radium-223, or discontinue hormone therapy and start abiraterone, or simply discontinue bicalutamide and continue leuprolide? Okay, you have you can vote. Please try to vote. Can you vote now to see the answer, please?
Vanessa, we don't have the voting.
Okay, let's skip it هلا. فإذا if we don't have the voting, Vanessa مع إنه محضرة كل شيء, I will go to the next. The answer is discontinue bicalutamide and continue leuprolide. Why? The patient has developed castration-resistant prostate cancer, and it's too late. هلا بينت عنا. So and he has no metastasis on the most recent imaging. So we show that he's started being resistant to hormone therapy, and he has been receiving agonist with anti-androgen, and the PSA doubling time was less than 10 months. So it was reasonable to continue to monitor the patient on simply agonist LH-RH without any therapy. Okay. And you know very well, the idea here is to discuss it, and I hope our urologist will discuss it later on. We have to maintain the androgen deprivation therapy all the time in order to maintain the castrate level of testosterone, whatever we decide to do. So we did that. We stopped the anti-androgen because there was no reason to continue the anti-androgen, as he is experiencing biochemical progression on this drug. Okay. The second case, it's a case of a 70-year-old man with metastatic castration-resistant prostate cancer who progressed through multiple lines of hormonal and chemotherapy, and he has good PS and is being assessed for enrollment in a clinical trial assessing the efficacy of the PARP inhibitor olaparib. We consider that in some countries, we don't have yet olaparib. So which of the following molecular traits confers the greatest chance for the patient to respond to olaparib? Which of these can you select, please? تعطينا الvoting, Vanessa. نحن we cannot vote. Okay. So again, the question again, which of these molecular testing alteration will give the patient the chance to respond to olaparib? So the answer is BRCA mutation, BRCA2, and I see that 75% responded right. Don't forget that the others also are somehow right, but the BRCA is the best one to give the greatest chance. Why? Because in a study of DNA repair defects and olaparib and prostate cancer with M1, patient with the BRCA had a great response to olaparib. We have to check that ATM, CHEK2, and Fanconi anemia gene also might have a response. No, still the BRCA is the best one. And we have also to say that the olaparib will not interact with the MSI level. So because MSI predicts the immunotherapy response. Okay, another case, 67-year-old patient presenting for follow-up with castration-resistant prostate cancer. He has M1, multiple metastases, but asymptomatic with a good PS. And recently, he progressed on bicalutamide, 1 tablet daily, 50 milligram. He has diabetes, he has epilepsy, hypertension, and receiving, as you can see, multiple treatment, metformin, metoprolol, loperamide, valproic acid, gabapentin for neuropathy. And the PSA is growing, but slowly. The workup, the bone marrow is working well, and the kidney function is good. So again, we have a PSA increasing 1.3 milligram per milliliter when under anti-androgen. So what's the next step to do? Should we go for chemotherapy since he has multiple metastases? Should we start with enzalutamide or any other anti-hormone with loperamide? Should we give diethylstilbestrol, or should we give sipuleucel T? So please mark your answer. So is chemotherapy or hormone therapy or metabolic radiotherapy the best choice? Okay, no one went to diethylstilbestrol. Okay, can I see the answer again? And the majority will go for medical treatment. Okay, so the majority equally will go to docetaxel, prednisone, or enzalutamide and loperamide. So I totally agree that in our condition, we will do that, but because we do not have sipuleucel T. But indeed, the answer is sipuleucel T. Why? Remember, the patient has 68 years old, okay, is relatively young, but he had multiple comorbidities. He had neuropathy, etc. And the PSA is growing slowly. This patient has a good PS, minimally symptomatic, and does not have visceral involvement. Why we are talking about visceral involvement? Because if you want to give chemotherapy, you have to get criteria of high risk, I mean, multiple metastases. So he might be a candidate for sipuleucel because he's asymptomatic, few lesions in the bone, and we have to say that the impact trial extends survival by about 4 months. This means that later on he might use the hormone therapy and the chemotherapy, but in this case particularly, it's good. Also, docetaxel would not be the ideal drug for this patient given his peripheral neuropathy, and enza is contraindicated given the seizure disorder. So in such a frail patient, we can postpone the treatment till a later phase. And diethylstilbestrol usually is associated with cardiovascular risk, which is not really indicated in such case. And indeed, we do not use it a lot. I also remind you that few people answered sipuleucel T just because we do not have it and we are not practicing really this treatment. The last case, it's a castration-resistant prostate cancer, relatively young, 67-year-old, many bone metastases. Okay, I want to... It's not the case. Okay, I'm sorry, Vanessa, it's not the right case. Okay, give me a few minutes. I will go to my slides. I'm sorry, but I will. And to my. Okay, so I will go to the last case. Can you see the new presentation or not?
Fadi.
Hey.
Hi, I'm Svani.
Hey, hi.
I could join now.
Excellent.
Very nice cases that you present.
Okay.
And especially about the CPT. It's a typical case. It was a typical case for SIPT. And you know, now SIPT in the States, it's a little bit regression. Because for many reasons. Because when you go and you see how these things are being done, يعني بتنقل من محل لمحل لمحل، لأن أول شيء بيعملوا collection بمحل، بيرجع بيعملوا sensitization بمحل, and then they join this. But classically speaking, now, even in 2022, because we crossed the 2021, yeah, definitely it's a يمكن هذا drug of choice. معك حق. That's the approval, by the way.
Yes. هلا we keep it for debate لأنه you might have different approaches يعني in some of these cases, but see to open the debate. طيب, the last case, I'm sorry, but I went to the
Yeah, but I'm not listening to anything, huh?
أنا مش عم بسمع شيء. في دكتور فادي، فانيسا.
It seems he's disconnected.
Dr. Farhat was disconnected.
So we will wait for him. Vanessa, Dr. Sameh Hashim joined us.
No, doctor, we will have the presentation with Dr. Bassem Youssef. You can check, please.
So the presentation is for Dr. Bassem.
Yes, with a new title.
The next lecture. Okay, perfect.
Yes.
Perfect. And I don't know what's happening. Would you like to call him by phone? If not, we will start with Dr. Bassem and come back again to the case presentation.
Sure, doctor, will do. Sure.
So we can come back to the case presentation number 4 and 5 after. Here, he's with us.
I'm sorry, when we stopped the case?
You should present case number 4.
Oh, okay.
فادي it's okay لأنه كله عم ينقطع عنا كل شيء.
ما بعرف أنا لأني عم غير. Okay, can you see my slides now?
Yes.
Yes,
okay.
We can.
يلا go ahead.
So, 61-year-old patient with metastatic castration-resistant prostate cancer received leprolide, abiraterone, enzalutamide previously and 6 cycles of docetaxel.
Both of them, Fadi? Both of them?
يعني exactly. It's a good question لأنه we know very well that it's not good to give abiraterone then after enzalutamide or vice versa. Data proved that. CARD trial said that it's not the best choice. But since it's case, yani to debate. So the first remark from Dr. Khaled and the first conclusion, don't give 2 lines of hormone therapy, abiraterone, enza, or vice versa. So the restaging showed progressive disease with the new liver lesion. So again, we have a new visceral metastasis. So we know that yani, we upgraded the disease, if we can see, from non-visceral to visceral. PSA with a doubling time less than 3 months, from 11 to 50. And he has bone pain now, but he's still PS1. So a PS1 receiving all lines of therapy except cabazitaxel and metoxantrone, what will you do? Should we go for chemotherapy, cabazitaxel, prednisone, or just refer to hospital, or give metoxantrone and prednisone? You know very well the trial of TANOC, which one of the first. Why not pembrolizumab? It's promising in many indications. Or why not radium, since he has pain, but he has liver metastasis? So what will be your answer? We have 85 participants. Thank you, guys, for being with us. So what will you do? Okay, so radium 223, no one voted. It's sad, but it's right. There is no place for radium 223 since we have liver metastasis. Pembrolizumab 14%, we haven't tested for MSI, so it's not the indication. Metoxantrone, Novantrone, and prednisone. We have to remember that in the TANOC trial, there was only improvement in quality of life. So it's not really used nowadays. We still use it exceptionally when we have no other drugs. Hospice referral, the patient is still PS1. I mean, he still can benefit from treatment or re-challenge with something of the previous treatment, or give a treatment. But the cabazitaxel and prednisone is still a good option, because cabazitaxel and prednisone is approved in second line. And even in some cases, in patients with comorbidity, you can use it in first line. It's approved also for that. So cabazitaxel and prednisone is the right choice. With that, I finished the presentation. I hope this presentation will open the session for the treatment, for the discussion of the treatment later on with Dr. Muhammad Musa and Dr. Khaled Ibrahim. Thank you very much. The floor is yours, dear panelist.
Questions هلا ولا بعدين؟
لا بالآخر when you finish the second presentation.
Okay, so هلا يعني في دكتور باسم يوسف.
Yes.
Okay, Dr. Bassem, he will present definitive and salvage radiation therapy for prostate cancer. Dr. Bassem is an assistant professor of clinical radiation oncology in the Department of Radiation Oncology in the American University of Beirut. Dr. Bassem, the floor is yours.
Good evening, everybody. Can you hear me?
Yes,
Yes,
Dr. Bassem.
Yes.
Okay, thanks. I want to thank Dr. Fadi Farhat and all the organizers for the invitation today. So let me share my screen. Can you see my presentation?
No, it's not shared.
Okay. Not yet, doctor.
Let me try again, yeah. Can you see it now?
Yes, now we see it.
Very good. Okay, so the topic of my presentation is definitive and salvage radiation therapy for prostate cancer. This is the outline of my presentation. So I'm going to start with a quick introduction, and then I'm going to discuss the role of radiotherapy for localized prostate cancer. In brief, I'm gonna present the role of hypofractionated radiotherapy, and then the use of adjuvant versus early salvage radiation for biochemical recurrence before I conclude. So prostate cancer is the second most common cancer in men worldwide. The incidence is of around 1.3 million new cases per year. Prostate CA is increasingly being diagnosed confined to the prostate due to screening with PSA. Now, most of the patients present with localized disease, around 78%. And we usually stratify these patients to different risk groups. And we use the tumor stage, the PSA value, the Gleason score, and the number and extent of cancer involvement in the biopsy course. So now we have 5 different categories: very low, low, intermediate, high, and very high risk. And now management for these patients with localized disease include active surveillance or definitive therapy, whether radical prostatectomy or definitive radiation plus or minus ADT. Now, to start with the group with very low and low risk prostate cancer, usually active surveillance is the preferred option for these patients. And the way we do it is with the follow-up PSA every 6 to 12 months. And the protocol we use is to repeat the DRE, MRI, and prostate biopsy every 12 months. And eventually, patients who desire active treatment or those who develop the disease progression have the option of treatment with prostatectomy or definitive radiotherapy. Now, we will start with management of patients with low-risk prostate cancer. I'll start with the PROTECT trial. This is actually the only randomized trial that compared surgery, radiotherapy, and active monitoring for patients with localized prostate cancer. Now, this study included mainly patients with low risk. 76% had T1C disease, 77% had low Gleason score of 6, and the median serum PSA was 4.6 nanogram per milliliter. About 1,600 patients were randomized, and about 550 patients were randomized into each of the 3 groups. The primary endpoint of the study was cancer-specific survival. And not surprisingly, the 10-year cancer-specific survival was very high for the 3 groups, 99%. So only 1% of the patient eventually died from his prostate cancer. And as we see on the right side, of the patients who initially chose active surveillance, about 55% eventually underwent therapy, whether surgery or radiotherapy. And the most important message from this trial is that for patients with low risk, the outcome using radiotherapy and surgery was equivalent. Now, moving on to patients with intermediate risk disease, usually we have 2 options for these patients, either radical prostatectomy or definitive radiation therapy with a short course ADT of 4 to 6 months. Now, this is the largest study on the use of definitive radiotherapy plus ADT for patients with intermediate risk prostate cancer, the RTOG 9910. It included around 1,500 patients with intermediate risk prostate cancer. About 85% had intermediate risk. The patients were treated with definitive radiotherapy, 770 gray, in addition of 8 weeks of concurrent ADT. The randomization in the study was to test the duration of neoadjuvant ADT. So in the first arm, the patients were treated with 8 weeks of neoadjuvant ADT. And in the second arm, a longer course of 28 weeks was used. The primary endpoint was disease-specific survival. It's important to note that in this trial, it was an older trial. The dose of radiotherapy was a bit suboptimal. And these are the results of the study. We can see excellent oncologic outcomes that were similar between the 2 arms. The 10-year disease-specific survival was 95%. The 10-year overall survival was 66%. As we know, many patients will die from other causes than their prostate cancer. especially that most of the patients with prostate cancer are old. The 10-year local control was very high, 95%. The 10-year risk of distant metastasis was very low, around 6%. And interestingly, we can see that around 27% of the patients will eventually develop biochemical failure at 10 years. Now, moving on to patients with high and very high risk prostate cancer. Again, we have the same two options. The first is radical prostatectomy, and the second one is definitive radiotherapy plus long-term ADT, which is 1.5 to 3 years. If we look at the most updated NCCN guidelines, we can see many options listed for patients with high or very high risk disease. And the one that is category 1 according to NCCN guidelines is external beam radiotherapy plus ADT of 1.5 to 3 years. They mentioned plus or minus docetaxel, and that's only for patients with very high risk disease. The second option is EBRT plus brachytherapy. And the third option is radical prostatectomy plus pelvic lymph node dissection, plus or minus adjuvant treatment according to the final pathology. Now I'm gonna start with the ASCEND-RT trial that was used for patients with high-risk disease. It was a randomized trial that included around 400 patients. 70% had high risk and 30% had intermediate risk. The patient had a total of 12 months of neoadjuvant ADT, and all the patients in this trial were treated to the pelvis initially, a total dose of 46 gray in 23 fractions after 8 months of neoadjuvant ADT. Now, the randomization was between an external beam radiotherapy boost to a total of 78 gray versus a brachytherapy boost to a total dose of 115 gray. The primary endpoint of this trial was biochemical progression-free survival, and the secondary endpoint was overall survival. These are the results of the study. As we see on the left side of the slide, the use of brachytherapy led to better 9-year biochemical progression-free survival, 83% versus 62%. But unfortunately, this was not translated into an overall survival benefit. It was 78% versus 74%, non-significant. And it is interesting that toxicity was increased with the use of brachytherapy boost, with the 5-year cumulative grade 3 GU toxicity of 18.4% in the brachytherapy arm versus 5.2% in the external beam radiotherapy arm. And this is why nowadays the use of brachytherapy is controversial, and not many people use it in practice because it increases toxicity and does not increase survival. Now, the second important trial in patients with high-risk disease is the POP-RT trial from the Tata Memorial Hospital. And this trial was very important because it was investigating the use of pelvis radiation versus prostate-only radiation for patients with high-risk disease. So it included 224 patients with high-risk disease. The inclusion criteria was Gleason score 8 to 10, Gleason 7 with a PSA of more than 15, Gleason 6 with a PSA of more than 30, or stage T3B or T4A disease. And the patients had to be enrolled if they had a risk of pelvic node involvement of at least 20%. The total duration of ADT was 2 years. The randomization was radiotherapy to the prostate only versus radiotherapy to the pelvis and prostate. What's also interesting in this trial that around 80% of the patients had adequate staging with PET PSMA, which is very sensitive for the detection of metastatic disease, whether in the lymph nodes or distant in the bone or elsewhere. The primary endpoint was 5-year biochemical failure-free survival. The secondary endpoint was disease-free survival and overall survival. These are the very interesting results of the study. So for the first time, a randomized trial has shown that when we treat the pelvis, we have improvement of the 5-year biochemical failure-free survival, 95%. This is quite a significantly high number for patients with high-risk prostate cancer versus 81% only for prostate-only radiotherapy. The same applied with the 5-year disease-free survival, the 5-year distant metastasis-free survival, and the 5-year overall survival. Now, interestingly, all was significant except for the 5-year overall survival with the 92% versus 91% non-significant. So after the publication of the study, it is now standard to treat the patients with high-risk prostate cancer to pelvic radiotherapy, followed by a boost to the prostate. Now, how about hypofractionation? Now, for patients requiring prostate-only radiotherapy, moderate hypofractionated radiotherapy is favored over conventional radiation. And this is according to several guidelines from the ASTRO, ASCO, and the AUA. And the reason is that it has similar efficacy and it allows the delivery of radiotherapy over a shorter period of time, 4 weeks versus 8 weeks in the standard fractionation. And these guidelines endorse either 60 gray and 20 fractions. This is the most commonly used fractionation in our department. And the other one that is also acceptable is the use of 70 gray and 28 fractions. On this slide, we can see the comparison between the standard fractionation versus the moderate hyperfractionation. And the two most important trials are the CHIP trial, which is shown on the left side of the slide. So in this trial, patients had a 5-year biochemical recurrence-free survival of 90% versus 80% when we compare it to the standard fractionation. Same goes for the PROPHET trial, which also used the same dose of radiation, 60 gray and 20 fractions. And again, the numbers were similar at 5 years, 5-year biochemical recurrence-free survival of 85%. And actually, this is the standard that we use nowadays for our patients. Now we will move to the next topic, which is adjuvant versus early salvage radiotherapy for patients with prostate cancer. Now, following radical prostatectomy, patients who have pathologic T3 disease, extracapsular extension, and positive margin are at risk of disease recurrence. We have randomized trial that showed that adjuvant radiation decreases the risk of biochemical relapse in this setting and may also improve overall and metastasis-free survival. However, the role of adjuvant radiation, particularly compared with early salvage, at the time of a biochemical relapse has been a matter of debate. So should we treat adjuvant for all the patients, or should we wait until the PSA rises to treat? And this randomized trial, actually one of many, the Radicals trial, attempted to answer this question. So it included around 1,400 patients who had a post-op PSA of less than 0.2 nanogram per milliliter and more than one risk factor. So PT3, T4, Gleason 7 to 10, positive margin, or a pre-op PSA of more than 10 nanogram per milliliter. And then the randomization was to either adjuvant radiotherapy, which is a planned use of radiation before 22 weeks after surgery. And the second arm is to observe and to only offer salvage radiation after a PSA failure, which was defined as a PSA of more than 0.1 or 3 consecutive rises. The primary outcome was freedom from distant metastasis. Now, eventually, the results have shown that for the patients who were randomized to the salvage radiation, 60% of the patients did not eventually need the radiotherapy, and hence they were spared from the side effects of radiation. Whereas in the patients who were planned to have adjuvant radiation, most of them did receive radiotherapy, around 93%. And upon salvage, the median PSA value was 0.2 nanogram per milliliter. So most of these patients were salvaged early. These are the results of the Radicals trial. The 5-year biochemical progression-free survival was 85% versus 88%. Very similar results with a p-value of 0.56, which shows that they are equivalent. Of course, there was a worse toxicity in the patients who had adjuvant radiation. Specifically, urinary incontinence was almost double, 5.3% versus 2.7%. And there was more urethral stricture in the adjuvant arm, 8% versus 5%, and the differences were statistically significant. So in conclusion, early salvage radiation is as effective as adjuvant radiation, showing similar 5-year progression-free survival, and early adjuvant radiation is associated with higher incidence of urinary complications. Now, in the setting of salvage radiation, the standard of care is to offer prostate bed radiotherapy only. Now, there was a trial that is called the sports trial that tried to address the role of pelvic radiation in this setting, as well as the role of ADT in this setting. Now, we already know that the standard of care for salvage radiation is to give radiation to the prostate bed, along with 4 to 6 months of radiation. And this was proven according to 2 randomized trials, the Genito-Urinary and the R2OG, that showed benefit in this approach. Now, in this randomized trial that was only presented as in the ASTRO 2008 annual meeting, it is not published yet. It enrolled around 1,800 patients with biochemical recurrence following prostatectomy. And these patients were randomized to either prostate bed radiotherapy alone. The second arm was prostate bed radiotherapy plus short course androgen deprivation therapy for 4 to 6 months. And the third arm received everything. So it received pelvis radiation followed by a boost to the prostate bed, as well as ADT for 4 to 6 months. So the results of the study were quite interesting because it showed that when we give everything to the patients, and treatment to the pelvis as well as ADT, they will have the highest 5-year freedom from progression, which is around 90%, 87%. And for those who received prostate bed radiotherapy alone, it was 71%. Now, this is quite an interesting study. It is still debatable whether we should treat the pelvis in this setting because the study was not published yet for peer review. So what we do in the clinic, we discuss on a case-by-case basis. Now, in conclusion, both prostatectomy and definitive radiation plus ADT are standard therapies for patients with localized prostate cancer. The choice of therapy depends on an informed patient decision, incorporating knowledge about the potential advantages and disadvantages associated with each approach, the side effects, and personal preferences. Radiotherapy can be complementary to prostatectomy in the setting of high or very high risk disease, and for patients who present with biochemical failure after prostatectomy. And finally, radiotherapy and surgical techniques are continuously evolving to improve the oncological outcomes and to decrease the treatment morbidity. And by this, I thank you for your attention.
Thank you, Dr. Bassem, for the excellent lecture. So the panelists now, if you have any comments, any discussion about the cases presented by Prof. Fadi and the lecture of Prof. Bassem, please, any comments, or from the audience, the participants, if you have any question, please let us know. Dr. Muna, do you have any comment regarding the radiotherapy lecture?
Maybe one question for Dr. Bassem. So you no more recommend adjuvant radiotherapy after a prostatectomy? So you wait for biologic recurrence, that's it?
Exactly. This is our current standard of care for most of the patients. As I presented the Radicals trial, actually there is now at least 3 randomized trials that compared adjuvant versus early salvage. And in all of them, it seems that the outcomes are equivalent if you treat upon recurrence as early salvage. Now, there is some exception to this rule, and it is for patients who have very high risk features. So I'll give an example. If a patient underwent a prostatectomy and he has a Gleason score of 9 or 10 with a T3, let's say, for these patients who are still on the safe side, and we are still offering adjuvant radiation with ADT. But for the rest, especially for those with a low Gleason score, we are just waiting. And whenever PSA reaches 0.1 or 0.2, this is when we are offering our salvage radiation plus or minus short course ADT of 4 to 6 months. By this, we spare the toxicity of radiation. As I showed you, 60% of the patients will be spared from radiotherapy and its side effects by using this approach.
Okay, thank you. And for hormonotherapy, when you have a biologic recurrence, so you associate, you use rather 3 to 6 months or 2 years of bicalutamide?
Exactly. Now, the randomized trial, the GETUC and the RTOG use different drugs in their salvage setting. What we do whenever we use ADT, we'd rather use the GnRH agonists, the Zoladex or the decapeptyl. Now, do we use it for all the patients? This is a controversial issue. And for all the patients who have a PSA of more than 0.6, we do offer it across the board. Now, for lower values of PSA, there is a controversy, and we do it on a case-by-case setting. So we really use the Gleason score to help us in this decision. For patients who have a high Gleason score, we tend to use ADT, whatever the PSA value is. Whereas if we have a patient with a Gleason 6 and a very low PSA value of 0.3, let's say, many people would use radiotherapy alone and they would accept to omit the ADT component, especially if a patient has like cardiac problems, to spare him the toxicity of ADT. So it's a very controversial topic, to be honest, and we do it on a case-by-case basis. The final decision of using ADT, of treating the pelvis or the prostate bed alone. It's an evolving topic, and we will wait for more studies to have a more robust recommendation for our patients.
Thank you. It's almost what.
So as I understood that now you are using the hypofractionation technique as a standard at your center, no?
In the definitive setting, yes. For patients who are treated with definitive radiotherapy, especially for those with low risk and intermediate risk, we are using hypofractionated radiation. For patients with high risk, we are not, because as I showed you in the POP-RT study, treating the pelvis improves the oncologic outcomes for these patients. And whenever we treat the pelvis, we are still hesitant to use hypofractionation. Many studies are being published nowadays, and maybe in the future we will do that. But high risk, we are still doing standard fractionation, 46 gray to the pelvis, followed by a boost to 78 gray to the prostate using standard fractionation.
So, okay, thank you, Dr. Bassem. We have a question here from the audience. Dr. Fadi, are you with us? Or Dr. Amal? Dr. Amal, are you with us to answer the question? Which is better to start, abiraterone or enzalutamide in metastatic castrate-resistant prostate cancer?
I'm here. I'm hearing you.
Yeah. Would you like to answer the question, Dr. Fadi?
Yes. So the question, which one to start, which one to use, abiraterone or enza? That's what I heard from your side, yeah?
Yes.
Indeed, there is no difference in efficacy. There is no comparative study head-to-head, but what you can do is to choose the toxicity profile. So if there is any seizure, for example, or risk of the CNS, it's better to avoid enzalutamide.
The internet is weak.
My internet is weak. Muna,
yes.
Can you answer the question, please, if my internet is weak?
Yes, sure. As Dr. Farhad said, it depends on the toxicity. It depends on the comorbidity of the patient. So if you have patient with diabetes, which is not well controlled, maybe we rather use enzalutamide, because we have not to use corticosteroids with enzalutamide. But and we have patients with seizure, with maybe we have to avoid to use enzalutamide. Otherwise, you know that with enzalutamide we have toxicity which is very, how to say it in English, which is asthenia and fatigue, and it's very for patient for active patient, it can be limited toxicity to use it.
Say it in French if you want.
Voilà, en fait, ce que je voulais dire en français, c'est que ça dépend de la toxicité, ça dépend des antécédents et des comorbidités des patients. C'est-à-dire que si on a des patients qui sont diabétiques, peut-être qu'il faudra éviter d'utiliser l'abiraterol parce qu'on ne pourra pas utiliser les corticostéroïdes. Pour les patients qui ont des antécédents d'épilepsie, il faudra peut-être éviter l'enzalutamide. Et surtout, il faudra penser à éviter l'enzalutamide chez les patients qui sont très actifs et sur le plan professionnel et sur le plan social, parce que qu'on le veuille ou pas, l'enzalutamide, ça donne une asthénie et une fatigue profonde qui peut être très, très embêtante chez ces patients-là. Voilà. Donc, en fait, ça dépend des patients et c'est au cas par cas, mais sinon, ce n'est pas sur l'efficacité qu'on va décider.
OK, merci. There is also a comment here. It's for Dr. Bassem. Obstructive problems are considered as contraindication for hypofractionation radiotherapy. Bassem.
Can you repeat the question, Dr. Farhat?
Obstructive problems are considered as contraindication for hypofractionated radiotherapy. It's a comment. Is it?
If the patient has obstructive symptoms?
Yeah. So we should ask.
Obstructive symptoms. So for patients that we treat with definitive radiotherapy, many of those could present with obstructive symptoms. And the reasons can be multiple. Some of those can have obstructive symptoms secondary to the tumor. Some of them have baseline of BPH before developing the cancer. So these obstructive symptoms can be managed. So our standard is to use neoadjuvant ADT for these patients for 2 to 3 months. And many of those do improve. Their obstructive symptoms do improve when comes the time for radiotherapy. On the other hand, if the obstructive symptoms are very severe, the urologist can help us by doing TUR to relieve the obstructive symptoms. So by itself, it's not a contraindication. Usually we avoid brachytherapy when we have severe obstructive symptoms because this technique increases the risk of urethral stricture. So yes, we can treat the patients with radiotherapy in this setting.
Okay, thank you. So if you allow me to go to the next session, Dr. Fadi. So Dr. Muna, would you like to present our first speaker, Dr. Muhammad Musa?
Yeah, sure. So Dr. Muhammad Musa is an associate professor of urology and chairman of the urology department of the Lebanese University and chair of the urology division at Al-Zahra Hospital in Lebanon. He will present treatment strategy for metastatic castration-sensitive prostate cancer.
So good evening, everybody. First of all, I would like to thank the organizing committee for inviting me to this 4th Multidisciplinary Oncology Congress 2021. I would like to thank especially Professor Fadi Farhat, who is very active all the time. My task today is to talk about the advances in metastatic hormone-sensitive prostate cancer management. As we know, the volume of disease as a potential predictor was introduced by the Chartered and also the Latitude trials. The randomized trials performed in the year 2013 were mainly focused on determining the relative value of intermittent versus continuous ADT in selected patients. Few years later, the positive result of the two-phase trials, the Charter trial and the multi-arm Stampede trial, both of which confirmed the superiority of docetaxel plus ADT, led to a paradigm shift. Consequently, this combined treatment approach became the new standard of care in selected patients. Abiraterone acetate was the first anti-androgen receptor inhibitor to demonstrate efficacy in metastatic prostate cancer. The findings of the Latitude and Stampede trial on G demonstrate that abiraterone acetate combined with ATT significantly reduced the mortality risk while prolonging radiographic progression-free survival. The long-term outcomes of the Latitude trial were recently reported, confirming the initial findings of the trial and showing that 66% of patients treated with combination therapy survived at 5 years. Although there were differences between the two trials in terms of the type of metastatic patients, high-risk de novo PCA in Latitude and any metastatic or non-metastatic patients in the Stampede trial, the results of both trials showed the combination therapy provided a clinical benefit in all patients profile. The median survival was 53.3 months, identical to that obtained with docetaxel 51.2 months in the Charter trial. The phase 3 Enzamet and Arches trial, both published in 2019, confirmed the value of enzalutamide in patients with metastatic hormone-sensitive prostate cancer, thus supporting the use of enzalutamide plus ADT in these patients. Although the profile of patients in the two studies was similar, there were clear differences in the study design. In the Enzamet study, patients were allocated to receive either enzalutamide plus ADT or first-generation anti-androgens plus ADT. By contrast, the ARCH trial compared enzalutamide plus ADT to ADT plus placebo. There were also differences in the primary endpoints, overall survival in the Enzamet trial and the radiological progression-free survival in the ARCHES trial. At the median follow-up of less than 36 months, the result of the Enzamet trial confirmed the benefit of the study drug, improved radiographic progression-free survival in all subgroups, 3 years overall survival of 80% in the enzalutamide plus ADT arm versus 72% in the comparison arm, ADT plus first generation anti-androgens, enzalutamide, flutamide, or nilotinib. Based on these results, the FDA approved enzalutamide for the treatment of metastatic hormone-sensitive prostate cancer in December 2019. The Titan study introduced the use of apalutamide in metastatic hormone-sensitive prostate cancer at a median follow-up of 22.7 months. The overall survival and the radiographic progression-free survival were comparable to outcomes obtained with the abiraterone acetate and enzalutamide in patients with similar clinical profile. At 2 years follow-up, the mortality risk was reduced by 33% and the radiographic progression was by 52%. This is how it is the Titan study, apalutamide plus ADT versus placebo plus ADT, radiographic progression-free survival versus, and the overall survival were documented. And this is from the primary analysis. It has shown that the risk of death reduced by 33% and the radiographic progression-free survival progression-free was reduced by 52%. And the final analysis of the Titan with a median follow-up of 44 months, LIDA plus ADT reduced the risk of death by 35%. And this is the presentation. This is they have done a crossover. Some patients from the placebo arm that went to get apalutamide plus ADT, and this final analysis of the Titan was that 48% reduction of risk of death after adjusting for 40% of patients with placebo who crossed to apalutamide arm. What is crossover adjusted overall survival? This is when you take some patients from the placebo arm and you put them in the apalutamide arm, and this is the inverse probability of censoring, weighing, validated, frequently used in oncology to adjust for bias of crossover patients. And this is the final analysis. Second progression free survival and time to castration resistance. In the second progression free survival, 38% reduction in risk of progression free survival second, and in the time to castration resistance, 66% reduction in risk of castration resistance. And this is the final analysis we've just talked about. And these are the side effects of the apalutamide. Grade 2 to 3 to 4 adverse events that are minimal. The rash occurs early. And in conclusion, the final analysis of Titan after a median follow-up of approximately 4 years confirmed that Erleada plus ADT consistently improved overall survival with a reduced risk of death by 35% compared to placebo and ADT in broad population patients with metastatic castrate-sensitive prostate cancer. After the adjustment of almost 40% of placebo patients who crossed over to receive Erleada, the risk of death was further reduced by 48%. Erleada provided a consistent benefit in other points, including delayed castration resistance and maintained health-related quality of life with a manageable safety profile and no new safety signals. And this is the pain progression favors Erleada, is reducing the pain, and in intensity and interference. Patients with severe pain at baseline had the most improvement. Addition of Erleada to ADT didn't increase the fatigue intensity or interference. And health-related quality of life side effect bother was preserved with the addition of Erleada to ADT. In conclusions, overall health-related quality of life was preserved with Erleada plus ADT in patients with metastatic hormone-sensitive prostate cancer, including those with high volume or low volume disease, previous docetaxel use, previous treatment for localized disease, previous or newly diagnosed disease. These data support the addition of Erleada to ADT for a broad range of patients with metastatic hormone-sensitive prostate cancer. With regard to androgen receptor inhibition in patients with low volume disease, patients in the ARCHES and ENZAMA trials were stratified by disease period, high versus low volume disease, the charted criteria. The findings of those trials provided further support for the potential utility of androgen receptor inhibitors in patients with low volume disease beyond the usual treatment indication in high volume, high-risk patients. And this is the follow-up of the patient of 3 years. Now we will come to ADT combined with chemotherapy for hormone-sensitive prostate cancer, metastatic prostate cancer. The 3 large studies were conducted, charted GetUp and Stampede. All trials compared ADT alone as the standard of care and ADT combined with mediatoxicitaxel. The primary objective of these 3 studies was overall survival. And ADT combined with chemotherapy in the 3 trials, toxicity was mainly hematological with approximately 12-15% grade 3 to 4 neutropenia, 6 to 12% grade 3 to 4 febrile neutropenia. Concomitant use of granulocyte colony stimulating factors receptors was shown to be helpful, and its use should be based on available guidelines. Taxane-based chemohormonal therapy for metastatic hormone-sensitive prostate cancer And this study has shown the review and meta-analysis has shown that docetaxel improved survival. Hazard ratio of 0.77% translates into an absolute improvement in 4-year survival of 9%. Docetaxel, in addition to the standard of care, also improves failure-free survival, translating in the reduction of absolute 4-year failure rates of 16%. Treatment of the primary tumor in newly diagnosed metastatic disease. The first reported evaluation prostate radiotherapy in men with metastatic castrate-sensitive disease was the HORA trial, ADT alone or ADT plus external beam radiation therapy. Patients with PSA more than 20 and the primary bone metastatic prostate cancer, median overall survival was 44 months, and in the radiotherapy group was 43 months. Overall survival was not significantly different if you do radiotherapy for the primary tumor in newly diagnosed. The STAMPEDE trial also evaluated men with metastatic hormone-sensitive prostate cancer who were randomized to ADT alone versus ADT plus radiotherapy to the prostate only. This trial confirmed that radiotherapy to those primary tumors did not improve the overall survival in unselected patients. And in the low volume subgroup, there was a significant overall survival benefit by the addition of prostate radiotherapy. High volume disease, it will not help. Low volume disease, it will help. Radiotherapy of the prostate with low volume metastatic disease should be considered then. Metastasis-directed therapy in patients relapsing after a local treatment and a limited number of metastases. A metastasis-targeting therapy has been proposed. The aim to delay systemic treatment. And this is the metastasis-directed therapy outcomes observation versus stereotactic ablation radiation of polymer or metastatic prostate cancer. This is the Oriole trial. And in this study, 54 men with recurrent metastatic hormone-sensitive prostate cancer and 1 to 3 metastases detectable by conventional imaging who had received ADT within 6 months and enrollment or 3 or more years total were randomized, subsequently underwent a PSMA PET scan. And the primary outcome was progression at 6 months by PSA level and level increase, progression detected by conventional imaging, symptomatic progression, ADT initiation for any reason or death. And in these patients, 16 of 36 participants treated with stereotactic ablation therapy had baseline PET avid lesions that were not included in the treatment. And the proportion of men with no untreated lesions had a progression at 6 months was 1 of 19%, 5% compared with 6 of 16 patients for those who with any untreated lesion. Stereotactic induced a systemic immune response and baseline immune phenotype and tumor mutation status may predict the benefit of stereotactic ablation radiotherapy, and the treatment with stereotactic ablation radiotherapy for oligometastatic prostate cancer improved outcomes and was enhanced by total consultation of disease identified by PSMA targeted positron emission tomography. These results underline the importance of prospective randomized investigation of the metastatic state with integrated imaging and biological correlates. Surveillance or metastasis-directed therapy for metastatic prostate cancer recurrence, prospective randomized multi-center trial phase 2 trial. And these trials, asymptomatic prostate cancer patients who had biochemical recurrence after a primary prostate cancer treatment with metastatic lesions and serum testosterone level more than 50. Patients were randomly assigned to either surveillance or entity of all detected lesion surgery or stereotactic body radiotherapy. The primary endpoint was androgen deprivation therapy, ADT free survival. At a median follow-up of 3 years, the median ADT-free survival was 13 months for the surveillance group and 20 months for the MDT group. Quality of life was similar between arms at baseline and remained comparable at 3 months and 1 year follow-up. Optimal treatment for metastatic hormone-sensitive prostate cancer, abiraterone acetate, and docetaxel yield comparable results. The management paradigm of men with hormone-sensitive prostate cancer has evolved rapidly over the past 5 years, while there are now multiple treatment options ranging from chemotherapy to use novel androgen signaling agents. The absence of comparative effectiveness studies leaves little guidance to clinicians and patients with regard to the optimal choice of therapy. Although there are no biomarkers to aid in optimal drug selection, indirect comparison of efficacy between combination approaches in this metastatic hormone-sensitive prostate cancer, systemic review, and network meta-analysis. All agents in combination with ATD were shown to be superior than ADT alone. Enzalutamide plus ADT had the lowest absolute hazard ratio compared with ADT alone, and estimated 76.9% probability that enzalutamide is the preferred treatment to prolong overall survival compared with other combination treatment or with ADT alone. Enzalutamide appeared to have better overall survival compared with docetaxel in men with low volume disease, but there was no difference in other comparisons. Comparison between abiraterone acetate, docetaxel with under ADT in high risk or metastatic hormone-naive prostate cancer, systemic review, and this has shown that indirect comparison of ABI ADT to doxy ADT demonstrate no statistically significant difference in overall survival between these approaches. And the comparison of current systemic combination therapy and selection of candidates for optimal treatment, and 10 trials with 16 publications, direct network meta-analysis consists of that androgen deprivation therapy combined with docetaxel, abiraterone, enzalutamide, or apalutamide could significantly improve overall survival and failure-free survival compared to ADT alone in men with metastatic hormone-sensitive prostate cancer. And these evidence synthesis surface under the cumulative ranking curve analysis demonstrated the superiority of ADT plus abiraterone or enzalutamide over the other therapies. Subgroups analysis indicated that additional abiraterone, the ADT, had the highest ranking in patients with high volume disease or visceral metastasis. You can orient it ourselves, enzalutamide for low volume, abiraterone acetate for high volume disease. Enzalutamide plus ADT outperformed other treatments in patients with low volume disease or without visceral metastasis. Different combination therapies had variable adverse event profiles, and ATD, in addition with docetaxel or abiraterone, had the highest risk of adverse events. Androgen receptor splice variant 7 predicts shorter response in patients with metastatic hormone-sensitive prostate cancer receiving androgen deprivation therapy. And this study has shown that 310 patients with metastatic hormone-sensitive prostate cancer, 21% they were ARV positive, 79% they were ARV7 negative. And compared to ARV7 negative patients, ARV7 positive patients had significantly shorter progression-free survival and overall survival. And these are the recommendations for even the follow-up that cannot be replaced by laboratory tests and imaging modalities. It is of utmost importance in metastatic situation to advise patients about early signs of spinal cord compression and to check for occult cord compression, urinary tract complication, ureter obstruction, bladder outlet obstruction, or bone lesions that cause an increased factor risk. And follow-up during hormonal treatment should be assessed by symptomatic response of the change in serum PSA level. Patient with very deflected plastic cancers, when PSA may not reflect tumor progression, we need imaging by PET scan. And it is recommended that bone densitometry and the levels of serum vitamin D and calcium should be measured in the commencement of ADT and every 2 years. And this is the follow-up curve guidelines for during the hormonal treatment. I would like to thank you for your listening.
Thank you, Dr. Muhammad,
Thank you very much
for the excellent lecture. And we will keep the question and answer after the second lecture. And if the panelist, Dr. Muna, allow me to present the next speaker. So our next speaker is Dr. Khaled Ibrahim, Clinical Associate Professor of Hematology Oncology at Beirut Arab University in Lebanon. And Dr. Khaled will talk about treatment and trials in non-metastatic castration-resistant prostate cancer. Please, Dr. Khaled, the floor is yours.
Good evening. I will start by thanking Professor Farhad for inviting me to be among this distinguished faculty. What I'm going to try to do today is to review some of the updates in 2021 metastatic castration-resistant prostate cancer. Why some? Because we have a tremendous evolution and revolution of treatment of mCRPC, as well as diagnosis and a new understanding about the philosophy and biology of this entity. Now, the burden of the disease, 20 to 40% of the patient treated for localized prostate cancer represent a biochemical recurrence during the 10 years after the local treatment, and 30–70% of them will develop metastatic disease. Now, less than 5% of patients present with metastatic disease in the EU, but up to 40% of men with locally advanced prostate cancer will develop metastatic disease. The most important thing that the average time to development of CRPC following the start of hormonal therapy is 2 to 3 years, and the median survival of CRPC is 1 to 3 years. So it's a real problem that we face. Well, you know, you are all aware about the treatment landscape, from the hormone-sensitive disease and the local therapy reaching many of the approved treatment in terms of chemotherapy, new hormonal treatment. And what we're going to discuss today is the new treatment that we are using in metastatic in mCRPC. It's not figuring here in this landscape slide. Now, I'm not going to stop on the phase 2 trials in metastatic PCA because probably it will be covered by our colleague, by my colleague urologist. By the way, it's a recorded session. It's not a live session. And I'm not going to discuss the data that you know about KUGA 302, 301, PREVAIL, AFFIRM, SIMCA, because we already presented and re-presented these data in many of our meetings. Now, what are the FDA approved agents for mCRPC? Androgen receptor targeting in 2011, abiraterone was approved, and then 2012 ENZA, cytotoxics, the first one, 1981, estramestin, 96, mitoxantrone, and then docetaxel with the TAC that you all know, and cabazitaxel is the last to be approved in 2010. What concerns immunotherapy, Sipuleucel-T in 2010, and then immunotherapy, Pembro in 2017. We should not forget Alsimca trial in the region 223 that was approved in 2013. Of course, every of these drugs, each of these drugs was approved in a context, in the clinical context. And the last thing that we're going to spend a little bit time discussing are the PARP inhibitors, olaparib 2020 and rucaparib in 2020. Now, 3 emerging approaches for prostate cancer that I want to discuss. I'm not going to repeat that. If we want to discuss everything that is happening in prostate cancer, it's a tremendous. We need 3 or 4 and maybe more presentations. Now, the first that I want just to brief you is the new chemotherapy and hormone therapy approaches. And namely, I'm going to talk a little bit about the CART trial, although my task is talking about hormonal treatment and new hormonal treatments. I would rather call it the new hormonal treatment trends. In CART trial, patients with MCRPC previously treated with more or equal 3 cycles of docetaxel and disease progression after less than 12 months, it's important, on ABI or ENZA, before or after docetaxel, doesn't matter. 255 patients randomized to cabazitaxel classical dose of 25 milligrams square meter Q3 weeks plus prednisone GCSF versus ENZA 160 QD or abiraterone 1000 QD, prednisone 5 milligram BID, also classical. And this continues until disease progression. The primary endpoint was the R-based, imaging-based progression-free survival as primary endpoint, and secondary endpoint or PFS, PSA, and many others, as well as safety. Now, reviewing the imaging-based PFS, it was tremendous, 0.54, with a very significant p-value in favor of cabazitaxel, which means, and it was published in the New England Journal of Medicine in 2019 by DeWitt. And this means a lot for us as urologists and as oncologists and neurologists. Means that we have a new standard of care that allows us to use cabazitaxel as first-line treatment. The same thing applies to overall survival with a significant p-value and a hazard of 0.64. So this is the first reminder of the CART trial that I wanted to do. The second one is the ASSESS trial, an interesting one, combining APA plus abiraterone versus placebo plus abiraterone in chemotherapy naive MCRPC. So this is a typical hormonal trial. Patient with MCRPC progressed on ADT, good ECOG, pain score less than 3%, no previous systemic chemotherapy, which is very important. The primary endpoint was also radiographic PFS, and the secondary endpoint, overall survival, time to chemotherapy, time to pain progression, and time to chronic opioid use. The design was APA plus ABI, 240, 1000 prednisone 5 milligram versus ABI, 1000 prednisone. 28-day cycle until progression of the disease, or withdrawal of consent, or unacceptable toxicity, patient receive ongoing ADT. Now, let me remind you that this, as we will see, the PFS, the radiological PFS benefit was observed across pre-specified subgroups, including patients with visceral metastasis and who were more than 75 years of age. Let me remind you that this trial is not yet, this combination, it's not yet approved. I don't know if it will be approved, but hopefully it's another way to go, especially when you look at the hazard ratio of 0.69 or the p-value of 4 zeros, well, it looks promising. Now, reaching PARP inhibitors, this is a very important chapter. It's a new chapter in prostate cancer, and it's maybe the most promising chapter in prostate cancer, where 23% of metastatic castration-resistant prostate cancer, they have the DNA repair alteration. Look at the right side, of the slide, 44% will have a BRCA2, 7% BRCA1, and others. If you look at it, it's very difficult to talk about these because they are very, very a huge number of alterations. And the most important thing that the frequency of DNA repair alterations increases with disease progression, which means each time that the patient is progressing, it's very important to look at the possibility of these alterations and subsequently to try to tailor some treatment for the patients. And 11.8% of these 692 men that were presented in a very elegant study by Pritchard in New England Journal of Medicine 2016, they had germline DNA repair defect. We don't have time to go in details what is germline, what is somatic. I assume that you are aware about the difference between both. A very important thing that not all men with germline mutations had a family history of cancer. Now, this is just to illustrate what happens and what is the frequency of DNA repair alteration. When we analyze the genomic landscape of advanced prostate cancer, it's a very schematic, and also I'm not going to swim in the mechanism of the PARP and DNA repair, but let me tell you what is going on in a very, very simplified way. Whenever we're having a single strand that is altered by the treatment by chemotherapy or alkylating agent, this DNA should be discarded into bracket, and the PARP is sitting there to leave these not be discarded. And when you use a PARP inhibitor, it's because what we need on the right side, a double strand that results in normal cell. I don't know if it was clear, but at the end of the day, the PARP is one of the functions of the PARP is to leave this bad DNA and let him live. Now, if you go and you analyze what are the functions of PARP enzymes beyond DNA repair, on the right side, on the left side, as I told you, the DNA repair with a single or double strand repair. On the right side, it has a very important function. It's a transcriptional modulator in terms of oncogenesis or oncogenes, tumor suppressors, and inflammatory genes. So it's a very important substrate to target. And the PARP are inhibiting this PARP, the PARP inhibitor. That's what we're going to discuss. The first very important trial, and it had very, very, very tremendous, unusual or unprecedented results, was the olaparib. Olaparib in patients with metastatic CRPC, it's a phase 3 trial in metastatic CRPC and progression on prior NHA that are harboring gene alternation with the role of HR in HRR. The two cohorts that were looked at, the cohort A with BRCA and BRCA2 or ATM alteration, around 300 patients, and the cohort B were the other alterations. An elegant one, olaparib 300 BID, conventional versus physician choice, or olaparib for the second cohort, olaparib 300 milligram BD. In 94%, it's 2-to-1 randomization versus physician's choice, and crossover was allowed. The primary endpoint, if you look at this in red, all these genes that were included in this trial, the primary endpoint was radiographic PFS in cohort A by RECIST 1-to-1 revised criteria, and the secondary endpoint radiographic PFS in both cohorts confirmed radiographic overall response rate in cohort A, and time to pain progression in cohort A, overall survival in cohort A. It is a very impressive These are very impressive results, unprecedented, by the way, in this setting. The cohort A, where BRCA1, BRCA2, and ATM mutation, look at its hazard ratio of 0.34 and a very, very significant p-value. And the response continues with time, 6 months, 12 months. So it's a very, very impressive result. The same thing applied to overall survival, where the hazard ratio was 0.69, less flagrant than PFS, but still it is significant in this setting. Now, the second PARP inhibitor that was looked at, it's Eucaparib in metastatic CRPC with HRR gene alterations, which is homologous recombination repair. Patient with metastatic CRPC and bad somatic or germline alteration in HRR genes, progression on AR-directed treatment for prostate cancer, and 1 prior line of taxane-based chemotherapy in the first trial. Chemotherapy was not allowed, no prior PARP, and no mitoxantrone cyclophosphamide or platinum-based. And this was very clear because they didn't want to contaminate the trial. Now, Eucaparib 600 milligram BID in 28-day cycle until radiographic progression or discontinuation for other reasons. Also look at the red line here. Also, it included all these gene alterations. What were the primary endpoints? Among patients with measurable disease, centrally assessed confirmed overall response by modified RECIST criteria, PCWG3, and among patients without measurable disease at BL, locally assessed confirmed PSA response more than 50% decrease rate. Now, if you look at the data of Titan, overall response rate in BRCA1, BRCA2 cohort, if you look at PR and stable disease is around 50%, which is significant. And the same thing applies to the confirmed PSA response rate. Now, what I wanted to tell you that this waterfall is just to illustrate the tumor response in BRCA1 and BRCA2 cohort. Now, what I wanted to tell you that probably in our patients who receive either a newer hormonal treatment or chemotherapy and hormonal treatment, it's very wise to look at the BRCA mutation, because probably, as I told you, around 20% will acquire this, and it will give us an opportunity to treat them with PARP inhibitor. Now, the second part of the discussion with the PARP and hormonal treatment is that there is a consanguinity, if you want, between DNA repair and AR pathway. So AR signaling, it's well known and shown that AR signaling regulates transcription of some DNA repair genes. So this is very important. And that PARP1 expression increases with prostate cancer progression, and some studies showed cross-regulation with AR signaling. So AR blockade enhances, at the end of the day, PARP inhibitor responsiveness. So that's why this is the wisdom behind probably combining those two treatments. And some of the combination trial, I cannot go into details, but the majority of them already published. The first line olaparib plus abiraterone, first line talazoparib plus enza, and the magnitude trial, first line niraparib plus abiraterone acetate and prednisone in CRPC. This is some citation how PARP now are being studied. That's why I wanted just to give you a flavor, because discussing all the data of PARP will be a tremendous work. So it's being combined with AR targeting agents, like I told you, with DNA damaging agents, with VEGF inhibitors, with immune checkpoints even, and targeting replicative stress. So, you know, I think the future will show many varieties of how we can use PARP inhibitors in our patient. Now, I think this is the last slide in this part. So how do we select patients with PARP inhibitors? So PARP inhibitor is currently used for treatment of metastatic CRPC. Yes, already we discussed this. Which mutations in DNA repair genes benefit from PARP inhibitor? BRCA1 or 2 may be the most sensitive, PARP2 somewhat sensitive, ATM may be sensitive, and others. We don't know because we didn't have, as I showed you in the study, we didn't have a lot of other alterations. Now, what we can use at this moment, that olaparib in the profound cohort genes, HRR genes including BRC, BRCA, and rucaparib in Triton 2, BRCA1, BRCA2, post-docetaxel only. And sequencing after AR target treatment, abiraterone, enza, olaparib maybe, because that's the evidence that we have. After chemotherapy and AR target treatment, rucaparib for now, because that's what we know now. Monotherapy is the current indication. The combination are not approved yet, to my knowledge, until yesterday. Now, the third part of the presentation is the PD-L1 immune checkpoint inhibition. Do we know about the other new FDA drug approved prostate cancer? Yes, Pembro. Pembro was approved in 2017, as I told you, for patients having an MSI high tumor. And if you look at the MSI high total duration of response, it's high whenever you are using in these patients with the MSI high solid tumors. Now, the Keynote 365 cohort B, Pembro plus docetaxel in pre-treated patient with CRPC, patient in this study with mCRPC and progressed PD less than 6 months before screening, failed or intolerant more than 4 weeks treatment with either abiraterone or enza, not both. Either abiraterone or enza, not both. It's important. No previous chemotherapy. Were randomized to Pembro 200 milligram plus docetaxel 75 to 3 weeks plus prednisone 5 milligram BD. Imaging assessment every 9 weeks through week 54 and every 12 weeks thereafter until progressive disease or PSA that was assessed every 3 weeks until PD. Co-primary endpoints, safety, PSA response rate, overall response rate by RECIST, version 1.11 BICR, and key secondary endpoint, radiographic PFS by BCWG modified RECIST version 1.101, and overall survival. If you look at the data or the results of the trial, these are impressive results. Not perfect, but if you look at the RPFS at 6 months was 76.9, at 12 months 26.2, you know, and the median overall survival was 20 with 6 months 96 and 12 months overall survival 79.9. I think this is my last slide, and the SMS in 2021 we have many promises, PARPs. PARP combination, AR combination, immunotherapy combination, and we should not forget about theranostics, especially now we had a very interesting data that was presented at the last ASCO virtual about theranostics. Maybe we will have the opportunity to discuss, although I'm not a specialist definitely, but to discuss these data from the point of view of oncology. Thank you very much for your attention.
Thank you, Dr. Khaled, for the excellent presentation. And now I let the floor to Dr. Mona. Dr. Mona, are you with us?
I will start by thanking
If you would like to take a question, I think that we have one question, and if the attendees and you have any questions, any discussion with our speakers.
Yes, maybe I have question for Dr. Muhammad and Dr. Do you have PARP inhibitors and immunotherapy in Lebanon or in Jordan or in Syria?
So you're asking me, I'm Dr. Khaled Ibrahim. Well, you know, it's not yet, the PARP inhibitor in prostate cancer is not yet approved. It's approved to my knowledge. It's approved in prostate cancer, in ovarian cancer.
Yeah.
But in prostate cancer, it's not registered yet. The same thing applies to immunotherapy. But let me little bit go to why I think what I presented. I think philosophically speaking, we are now getting into the last phase of the era of ARs in prostate cancer. I don't know if you share my opinion, but I think having new targets and new philosophies is the future. This is one. The second thing, what is very interesting and very intriguing, this finding that started. I don't know if you are interested in, but it started around 7 years ago, talking about the consanguinity between AR and PARP inhibitors, and I think it's a big future. I think it's a big future. Starting, the single agent was tremendously good, but combination maybe it's very promising. I think that's the second phase of treatment of prostate cancer. I don't know if you share this opinion concerning immunotherapy. The data of what we have now, it's good, but it's not so good to shift our practice to immunotherapy in this situation. Are you hearing me?
Yes, I agree with you when you say that ER is not enough alone. Combination treatment is the optimal treatment, even though in sensitive hormone disease or resistant castration disease. That's an evidence. Unfortunately, in Tunisia, we don't have all these therapies. We only have abiraterone and docetaxel. So we have to manage with these two.
I think you're doing the best thing, because what I was presenting, maybe someone is sitting in somewhere in another place than Lebanon, with all our crises. But what I was asked for is just to give a flavor what is going on. And by the way, theranostics are very, 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 very interesting, but I'm not an expert. On the other hand, I wanted just in 20 minutes just to give a very, very concise. But your question اللي هو كتير هيك ناعم بتونس, what you asked me, انه هلا انتوا يعني you have this big crisis and you're talking about a combination. I understand you, but this is a theoretical. In Lebanon now, yes, I can understand your question concerning PARP inhibitors, and it's not only PARP inhibitors, many things. but that's what that is going on. It's you know, it's a very small discussion between experts dealing with this field, in this field. That's why I told you that's it's a very promising drug.
Okay, I have another question for both Dr. Mohammed and Dr. Khaled. In the oligometastatic disease, when you have only adenopathy, pelvic adenopathy or lumbo-aortic adenopathy, which combination would you use? ER with abiraterone or ER with taxane? In hormone-sensitive disease.
In oligometastatic?
Yes, just adenopathy.
Well, why should I use both?
When you have,
you know, this is a very debatable question. You know, in oligometastatic, maybe I will go to surgery first.
Even with adenopathy, pelvic adenopathy, lumbo-aortic adenopathy.
Maybe I can answer the question. Hello, everybody. I'm Dr. Musa. Let me a little bit, if it's coming to surgery, I would like to answer it. First of all, I would like to thank Dr. Farhat, and I would like to thank all the panelists. In case of oligometastatic, I mean, it depends on how many lymph nodes you are having. We are doing routinely PET scans in Lebanon, PSMA PET scans. And if it's only in the pelvis, maybe we can, if it is operable, we will try to remove them. We are surgeons and we will try to remove them. But if it is going up, retroaortic, it's going up, it is a high volume disease, then we'll consider other treatment options. Depends on the risk of the prostate cancer. Is it a high risk disease or a low risk? It depends on the Gleason score of the patient, and if on the age of the patient also, how many age. We have many options to try. Maybe we can, I have a patient with retroperitoneal lymphadenopathies, and he is young. He was around 49 years. And we have started with him treatment with abiraterone acetate because it's doing well with the high volume disease. And after 6 months, he started with a PSA of 120. After 6 months, his PSA was 0. Then we have done him a combined adjuvant radiation therapy, and he is now put on abiraterone acetate and anti-androgens. And he's doing very well. I mean, it depends on each case. But if we have 1 or 2 lymph nodes in the pelvis and we have a young patient, we
operate on them. You operate on them.
Yes.
That's what I was trying to tell.
Yes.
Thank you, Muhammad. It's a very important replic.
Yes.
So this is a multidisciplinary discussion, and this takes us to a multidisciplinary discussion in this situation. I don't think that oligometastatic disease can be managed by one person. I think 3 or 4 persons or 3 or 4 personnel specialty should discuss. But when I go back to the question, do you start abiraterone and enzalutamide? I don't think there's a difference between both. I don't think. Maybe they selected to give Abi. Actually, I use Abi more because Abi was available in Lebanon before Enza, but I don't think there is a difference between them, except.
I mean, Khaled, as Dr. Muna said for her before, that it depends on the patient. If he's having diabetes,
yes, that's it.
You will not give abiraterone.
That's the toxicity. That's the toxicity, my dear.
Yes,
that's the toxicity. No more, no less.
The toxicity.
The toxicity, and another thing which is very important is the acquaintance, how to deal with the drug. And this is important because sometimes you feel that, yes, you know, theoretically, both drugs are very good, but you are acquitted with one drug, you go ahead and you use it because you don't have the time and sometimes the expertise to go ahead in details of drugs. But I concur with you 100% with those both. Even when you go with APA, the thing that you discussed, these are drugs that are beautifully managed, and if you start by using them, I don't think there's a big difference between them. I don't know if you agree.
Thank
And
you.
if I may comment from a radiation oncology perspective,
Yes.
you know, the NCCN guidelines also include radiotherapy as an option in addition to ADT plus abiraterone in patients with node-positive disease. They have a specific regional risk group that really includes patients with node-positive disease, specifically pelvic lymph nodes. So definitely surgery is an option for very select patients, I would say. But if a patient presents with multiple pelvic lymph nodes, another option could be hormonal therapy plus pelvic radiation.
صار لي زمان ما شفتك أنا. Yeah, that's what it's a multidisciplinary discussion. It's a multidisciplinary discussion. Yeah, sure.
Absolutely.
Yeah. It is true, very important in every center to have multidisciplinary clinic to discuss every case, even if it is straightforward, just to have the best approach for the patient. So if you allow me, speakers and panelists, to make the closing remarks of this activity, I would like to thank you all for being with us. I would like to thank the participants from all over the MENA area, also the organizing company Science Pro, and just to let you know that our next course will be next week on September 21st about hematology, and please save the date and good night.
Thank you so much. It was a
Thank
great.
you, everybody.
Thank you.
Thank you.